My name is Khayyal Abdelkader. I am a associate consultant at the Oculoplastic division in KKH. I'm pleased to welcome Dr. Mashael Khayyal, who is my classmate and colleague as well. Dr. Mashael completed her fellowship at our hospital here in KKH, and then completed an specialized orbital fellowship at McMaster University under the mentorship of Dr. Yasser Khan. She's going to be talking about biofilm-associated infections, which is becoming a more and more common problem that we're starting to encounter more often, and I'm sure we're going to benefit from her presentation today. Please welcome Dr. Mashael Khayyal. Thank you.
Assalamu alaikum. Good afternoon, everyone, and thank you for attending this grand round. So I'll be talking about biofilm-associated infections in oculoplastic practice. So the main objectives of this grand round is to understand what biofilms are and how they form, and to recognize common biofilm-associated infections in oculoplastic practice, to appreciate why these infections are difficult to treat, and to apply evidence-based strategies for prevention and management. So to start with, why biofilms matter in oculoplastics. Biofilms can cause recurrent or chronic infections despite antibiotics. It has a high association with silicone tubes, punctal plugs, orbital implants, prostheses, sutures, foreign bodies, and last but not least, fillers. It can lead to increased morbidity, prolonged courses of antibiotics, repeated surgeries, and patient dissatisfaction. It can lead to delayed management and unnecessary investigations. So by definition, a biofilm is a structured community of microorganisms embedded in a self-produced extracellular polymeric substance adherent to a surface. This surface could be a biotic surface, such as tissue or organ, or a biotic surface. It has certain key characteristics, such as reduced metabolic activity, altered gene expression, increased resistance to antibiotics, and host immunity. So the biofilm, to mature, has to go through 4 stages. The first one is the initial attachment. When free-floating planktonic bacteria approaches a surface, weak reversible forces mediate attachment, and we do have a lot of susceptible surfaces in oculoplastic, as we mentioned, such as the tubes, the punctal plugs, the implants, prostheses, and fillers. Bacteria can still be removed in this stage by irrigation, blinking, or immune clearance. Early antibiotic therapy may still be effective, and it is a reversible stage, and it's often a missed opportunity if surfaces remain colonized. The second stage is irreversible attachment, where the bacteria express adhesions, firm anchoring to surface occurs, gene expression shifts toward biofilm phenotype. It passes through important molecular changes, which is upregulation of adhesion genes, downregulation of motility genes, and the initiation of extracellular matrix production. Simple antibiotic therapy becomes unreliable in this stage, and biofilm development proceeds even if symptoms are mild. The third stage is the maturation, where the extracellular polymeric substance form. The bacteria secrete a protective matrix composed of polysaccharides, proteins, lipids, and extracellular DNA. This matrix anchors bacteria together, physically blocks antibodies, and impairs immune cell access. Channels form within the biofilm, nutrients and waste products circulate, and oxygen gradient develop. Bacteria deep in the biofilm enter slow-growing or dormant phase or state. Most antibiotics target actively dividing bacteria, so dormant bacteria can survive this treatment. And this explains the partial response followed by relapse. The last stage is the dispersion. When portions of the biofilm break off, bacteria revert to planktonic form, spread to adjacent tissues, and this will result in intermittent acute exacerbation or periodic discharge. Antibiotics temporarily will improve the symptoms, but do not eradicate the source. So common biofilm forming organisms in oculoplastics are Staphylococcus epidermidis, Staphylococcus aureus, including MRSA, Pseudomonas aeruginosa, and Cutibacterium acnes, as well as different bacteria, gram-positive, negative mycobacteria, fungi, and even viruses can produce biofilm. Why biofilms are hard to treat? As we mentioned, the antibiotic penetration is limited. Slow-growing bacteria are less antibiotic sensitive. It has more than 10,000-fold tolerance to antibiotics. Biofilm matrix shields bacteria from immune responses. Standard cultures may be negative. And always remember that antibiotic failure in biofilm infections does not mean that the antibiotic is wrong. The diagnosis of biofilm infections has some clinical clues, such as chronicity, systemic signs, negative or inconsistent cultures, especially in cases related to facial fillers. We can visualize the related complication or infections. Tissue biopsy can help as well, followed by molecular technique can accurately identify biofilm-forming pathogen, enabling targeted treatment. So here are two different cases, which has a tear trough-related filler biofilm infection, and we can see it clearly in the MRI. We do have three principles in the management of biofilm infection. The first is mechanical disruption by debridement or curettage. The second is targeted antimicrobial therapy, culture-guided if possible. And we have to bear in mind that prolonged courses may be needed. And we should address the nidus by replacing or permanently removing the infected material. So moving on to the biofilm-associated conditions in oculoplastic practice. To start with is canaliculitis, which is a classic example of biofilm infection. The biofilm form within the canaliculus, actinomyces or mixed bacterial colonies can be present. Usually patients will present with persistent recurrent discharge despite antibiotics with a pouting punctum. The management, as we all know, canaliculotomy and curettage, removal of the concretions with adjunctive antibiotics. Second example is the anophthalmic socket and biofilm infections. So a significant proportion of chronic or recurrent discharge is now understood to be biofilm-driven rather than acute infection. And the socket provides an ideal environment for biofilm formation due to foreign materials, the implant and the prosthesis, warm, moist environment, reduced tear turnover, altered local immunity, and colonization by skin and conjunctival flora. Patient usually will present with persistent or recurrent mucoid or mucopurulent discharge, mild socket irritation or foreign body sensation. Temporary improvement will happen with topical antibiotics and rapid recurrence once the treatment stops. Red flags suggesting biofilm infection are long-standing discharge for weeks to months, multiple failed antibiotic courses, negative or inconsistent cultures, and associated prosthesis intolerance. So regarding the management, we have first to rule out other causes of discharge, such as giant papillary conjunctivitis or pyogenic granuloma, and then we have to mechanically disrupt the biofilm by polishing and cleaning the prosthesis, temporary prosthesis holiday in selected cases. And to address the nidus, we have to evaluate for poor prosthesis fit, rough or scratched surfaces, exposed implant, or retained sutures or hardware, as well as adjunctive medical therapy, topical antibiotics, culture-guided if possible, short courses only. We should avoid prolonged suppressive therapy in sockets, infection, and lubrication to reduce friction and inflammation. Also, we have to keep in mind deeper infection or deeper biofilm infection when to suspect implant-related biofilm. We should consider deeper pathology if there is discharge that is persistent despite prosthesis optimization, there is pain, swelling or implant exposure, and there is recurrent conjunctival breakdown as we see in this picture. Imaging and surgical exploration may be required in these cases. So here is an example of biofilm-related infection in an orbital implant. We can see that the patient kept on progressing despite broad-spectrum IV antibiotics. Culture eventually showed mycobacterium, and the implant was eventually removed. Here, the CT scan, we can see the significant orbital inflammation and an exposed implant in the picture below. Some of the prevention strategies, we should have smooth, well-polished prosthesis, proper socket reconstruction, early management of socket inflammation, regular ocularist follow-up, and early intervention before biofilm mature, and regular cleaning. So regarding the ocular prosthesis cleaning, how frequent should we advise the patient to clean their prosthesis? Here is a nice review that the authors proposed a model of response of the anophthalmic socket to prosthetic eyewear and its application to the management of mucoid discharge. So basically, they suggested three-phase model of the socket response to prosthetic eyewear. The phases are initial period or newly polished period where the prosthesis homeostasis is being established or re-established within the socket. The second period, which is the equilibrium phase, where beneficial surface deposits have built up on the prosthesis and where is safe and comfortable. The third stage, which is the breakdown phase, where there is an increasing likelihood of harm from continued wear. So 53% of the members of the American Society of Ocularists recommended to patients that they remove and clean their prosthesis whenever the socket felt irritated or whenever it's dirty. However, this suggests that the prosthesis should be cleaned after the breakdown of the physiological homeostasis has occurred rather than before, which has a risk of biofilm formation. Taking into consideration the three-phase model of the socket's response to prosthetic wear, it is recommended that prosthesis should be cleaned not more frequently than monthly and not less frequently than 6 monthly. Another interesting study I found, which talked about the inflammation level and microbiological analysis of the anophthalmic cavities of unilateral ocular prosthesis users. So basically, they did microbiological analysis of anophthalmic cavity and ocular prosthesis in 16 patients. They measured the bacterial count initially, 15 days, and 30 days post-polishing. During the polishing process, they used universal aluminum oxide polishing paste. As we can see in the two diagrams, the first one illustrates the anophthalmic socket, and the second is the ocular prosthesis bacterial count. So they found that the bacterial count to be lower at 15 days post-polishing, which makes sense, but continued to decrease by day 30. So the dark gray illustrates the total bacterial count initially, the first one, followed by the dark red, which represents the total bacterial count 15 days after polishing, and the light gray, which shows the total bacterial count 30 days after. So the bacterial counts kept on lowering 15 days after the polishing and further after 30 days after the polishing. So by 1 month, there was less and less bacteria in the prosthesis. Unfortunately, the patients lost follow-up due to COVID in this study, but it is interesting to see when does the bacteria comes back again or goes up again in the prosthesis in future studies. So what to use to clean the prosthesis? This study evaluated 3 cleansing solutions to clean the prosthesis and compared between them. The aim was to evaluate the ocular prosthesis biofilm formation and the level of contamination of the internal portion of the ocular prosthesis and the anophthalmic socket in 24 patients. Material was collected from the anophthalmic cavity and the ocular prosthesis at the beginning of the study and 15 days after cleansing of the prosthesis with 3 cleansing solutions: liquid soap, multi-use solution for contact lens, and chlorhexidine. Bacteria found were similar to the published literature, aerobic microorganisms, gram-negative bacilli, and Staphylococcus aureus. Although not statistically significant, but chlorhexidine washed prosthesis showed less intense bacterial growth in the biofilm or anophthalmic cavity compared to the use of other solutions. Moving on to the last condition, which is tear trough filler biofilm infection. We know that all fillers support biofilm formation, and tear trough filler has a higher risk for biofilm infection due to several factors. Some anatomical factors include thin skin and minimal subcutaneous tissue, proximity to eyelid margin and skin flora, poor lymphatic drainage, and limited immune surveillance in that area. Procedural factors such as needle or cannula passes through colonized skin and potential microseeding of bacteria at injection. The pathogenesis is the same basically for any biofilm formation. It starts first with the bacterial enucleation from the skin flora during injection and often occurs despite appropriate skin prep. Second stage, which is the adhesion to filler material, where the hyaluronic acid acts as a scaffold. Bacteria adhere via surface adhesions. Early colonization may be silent. Biofilm maturation, where the extracellular polymeric matrix forms, bacteria enter a low metabolic state, antibiotic tolerance develops in this stage, and the intermittent activation secondary to trauma, filler migration, immune changes, where the biofilms start to shed planktonic bacteria that causes episodic inflammation or infection. Usually, the presentation is variable. Patient can present with delayed onset swelling, weeks to years post-filler. It can present with erythematous rash, pimple-like lesions, red tender nodules, asymptomatic lumps, swelling, induration, and discoloration of skin can happen, or frank cellulitis, with or without fistula in rare cases. Also, it's commonly present as recurrent flares after partial improvement. Some of the red flags that suggest biofilm infections: poor or transient response to antibiotics, recurrence after steroids, fluctuating course, culture negative aspirates, history of previous filler at the same site, and recent procedure or trauma. Common misdiagnoses are delayed hypersensitivity reaction, granuloma, or idiopathic orbital cellulitis in early cases. So regarding the management, we should always maintain high suspicion, especially in delayed or recurrent tear trough inflammation with a prior filler history. Try to get the name of the filler if possible. Avoid steroids alone because it might suppress the inflammation and can worsen underlying infection, and there is a risk of masking the progression. We have to remove the biofilm nidus by dissolving the filler, of course, to disrupt the biofilm structure. Often results in dramatic improvement, and multiple sessions may be required. So here's a nice article that talked about the different percentages or units of Hiring days regarding or in relation to the different sizes of the nodules and tear trough related biofilm infections. Here you can see, for example, in nodules that are 5 millimeter or less, 45 units of Hiring days are enough to resolve it and solve the issue. Not to forget, we have to keep the patient on broad spectrum antibiotics, azithromycin or clarithromycin, and ciprofloxacin or moxifloxacin. Prolonged courses may be needed in these cases, up to 6 weeks. Antibiotics are supportive, not definitive, as we mentioned, and surgical intervention might be needed, but reserved to abscess formation, needle drain and culture, or persistent nodules are responsive to conservative therapy. Criteria of recovery are absence of symptoms for at least 2 years. So in summary, biofilms are a structured community of bacteria encased in a protective extracellular matrix, forms on implants, prostheses, fillers, and chronically inflamed tissue, major cause of chronic recurrent delayed onset infections. Bacteria are metabolically dormant, functionally antibiotic resistant. Failure of antibiotics should prompt suspicion of biofilm disease. Mechanical disruption or foreign body material removal is a key management along with prolonged antibiotic coverage. Here is my references. Thank you.
Thank you, Dr. Mashael, for such a nice presentation with really great studies. I just had actually 2 questions. My first question was, you mentioned that the filler-related biofilm infections resolve usually after multiple sessions of dissolving the fillers. I was just wondering how many sessions is usually needed. My second question is after your studies or after looking at the literature, did you find anything that was related to intralesional antibiotic therapy inside these areas of previous filler related infections?
So thank you, Alia. So regarding the first question, these sessions, there was an article that recommended dissolving the fillers twice weekly for 2 to 3 weeks, or whenever the nodule disappears. So whichever is longer, just follow it. And the second question, injecting antibiotic locally, they tried it, but dissolving the filler was, or removing the infected material was the ultimate treatment. And there's some studies that mentioned injecting 5-FU and steroids to improve the local inflammation.